Hi, my name is Lauren Diapoli, and this is a presentation regarding magnesium supplements' potential effects on stage 1 hypertension in adults. Magnesium is a vital nutrient that's involved in many enzymatic reactions. It is a cofactor for numerous biological processes. Low magnesium levels have been associated with constipation, metabolic syndrome, depression, hypertension, stroke, epilepsy, type 2 diabetes, cardiovascular heart disease, and studies have also found that magnesium supplements have improved symptoms in patients with migraines, asthma, preeclampsia, and coronary artery disease. Magnesium is vital for bone mineralization. Also, by forming positive ions, magnesium is essential to the breakdown of numerous nutrients and cellular materials. It assists in the ion channel regulation as part of the active transport of calcium and potassium across cell membranes. Magnesium reduces the risk of blood clotting by reducing platelet aggregation. Blood pressure is affected by magnesium because it helps to stimulate the production of vasodilator. I'm not going to pronounce this correctly, prostaglandins and nitric oxide, which modulates vascular tone. Adequate magnesium levels have shown to reduce arrhythmias, insulin resistance, and cardiovascular heart disease. Despite the importance of adequate magnesium intake, approximately half of Americans don't consume the recommended amount of magnesium in their diets. There are numerous sources of magnesium, and some of them are almonds, spinach, bananas, avocados. And even though magnesium is so important, as I had just listed in all of those vital functions in our body, a lot of people don't eat an adequate amount. Through research, I found it said approximately half of Americans, but I would say it's probably more than half of the people I know eat low amounts of spinach. They might have an occasional banana and guacamole, but very infrequently do I see people eating a lot of almonds or seeds, black beans, things like that. Magnesium deficiency can also result from reduced absorption, alcoholism, hypothyroidism, drug-related malabsorption, chronic diarrhea, and pancreatic problems. So even if someone is eating an adequate amount, some of these things could create a deficiency. And groups that are higher risk for magnesium deficiency are people that might have Crohn's or celiac disease, regional enteritis, intestinal bypass surgeries, diabetes, acidosis, chronic kidney disease. Small reductions in tissue magnesium is undetectable, so magnesium deficiency frequently goes undiagnosed. Also, because the initial symptoms of magnesium deficiency are kind of vague, they might appear to be related to other things. So testing might not be done for that right away because early symptoms are simple things that include nausea, vomiting, loss of appetite, which could be from a number of things. But when plasma magnesium concentrations fall below normal range, patients might notice things like tremors, muscle weakness, tetany, cramping, twitching, and other muscular-related things. Magnesium deficiency is also a known risk factor for the development of hypertension. And since hypertension increases the chance of developing cardiovascular heart disease and increases our risk of fatal instances of cardiac events, it really is so important to study ways to avoid deficiency. Cardiac arrhythmias have been associated with low serum magnesium, and severe arrhythmias or atrial fibrillation can lead to blood clots, stroke, and heart failure. So just more reasons why we really need to be on top of magnesium levels in the body. As deficiency worsens, related metabolic effects and central nervous system symptoms can occur. Things such as decreased parathyroid hormones, involuntary eye movements, hallucinations, confusion, irritability, restlessness, and even severe things like psychosis and seizures, and also drops in serum potassium and calcium, which can affect numerous other processes in our bodies, all of the things that potassium and calcium are responsible for. Studies have also demonstrated that there is a correlation between low serum magnesium levels, urinary magnesium secretion, and high blood pressure. So all things that kind of give us more direction as to where we need to continue studying. We know that the majority of the magnesium in our body is actually in our bones and cells. Only 1% of our body's magnesium is in our blood serum. This makes testing serum magnesium levels really an insufficient indicator of our total magnesium. So someone may be deficient and their serum magnesium level isn't going to tell their doctor that. And despite the vast body of research that we have currently published regarding magnesium's relationship to blood pressure or cardiovascular heart disease, serum magnesium analysis decreases the value of their findings. So any study that used serum magnesium level as a biomarker may not be as useful as we once thought. The proposed study that we're trying to design here determines if supplementing 350 milligrams of magnesium daily for 4 weeks in adults with their first reading of stage 1 hypertension, will that return their blood pressure to a normal range? So basically what I'm trying to say is if a patient comes in for the first time with an abnormal blood pressure, will 4 weeks of 350 milligrams daily return their blood pressure to normal? And this type of study can help us find an approach to early intervention for stage 1 hypertension. The research question is, do adults ages 35 to 60 who have a systolic blood pressure between 140 and 159 and a diastolic blood pressure between 90 and 99 show an improvement in blood pressure rate with a daily 350 milligram supplement of powder magnesium and a 4-week follow-up? And my hypothesis is that daily intake of the 350 milligram powder magnesium supplement for 4 weeks will return blood pressure to a normal range in patients aged 35 to 60 who've just been monitored as stage 1 hypertensive. A quantitative research study will be completed with parallel groups of patients ages 35 to 60 who have stage 1 hypertension, which the criteria was, as I had mentioned on the last slide, and will mention again, for the first time at a checkup in their general practitioner's office. So in order to be considered in the stage 1 hypertension range, patients have to have a systolic blood pressure between 140 and 159 and a diastolic blood pressure between 90 and 99. All of the eligible participants are individuals who in previous doctor visits had normal blood pressure ranges all the time. So they had never once had an abnormal blood pressure reading. Exclusion criteria limits individuals with a history of kidney disease, missing a piece or an entire kidney, chronic kidney infections, cardiac events, cancer, use of diuretics or antihypertensive drugs, previous instances of hypertension, digestive disorders, smoking, or alcoholism. Individuals who are eligible according to their blood pressure rate will be asked to confirm that they do not have any of the conditions that would exclude them from this study. Their doctor will additionally need to confirm this by checking with the individual's records, and they're allowed to do that because this is their own physician. The entire study process and some of the details about the importance of this study will be explained to the eligible patients. Interested eligible individuals will be given the consent letter to read and review and are given alone time to consider participating in the study while they wait for their doctor to come into the room, and they can take more time as they need afterwards and can schedule an appointment to come in for their initial intake. If anyone at any time during the study feels any adverse reactions from the supplement at any time, they can immediately stop taking it and come in to see their doctor. Completion of the study is not required, but anyone who does not complete it will not have their data included in the study. Participants can only miss or skip 1 day throughout the length of the study for their data to be included in the final results. Upon agreement to participate in the study, the patient's blood pressure will be taken 3 times, 4 minutes apart, and recorded. Blood pressure will be taken by a registered nurse in the doctor's office using an Aneroid device. An identification number, which will only be known by the patient, the doctor, and the nurse, will be given to each patient for recording purposes. The top of the jar that they will receive will be labeled with the patient's personal identification number in a magic marker. Every other participant will be given jar A, which has a powder magnesium citrate and a scooper that will provide them with 350 milligrams of magnesium to be dissolved in water and consumed once daily for 4 weeks straight. The individuals who are not given the magnesium supplement are given an identical-looking powder placebo in a jar labeled B. Neither the physician providing the jars nor the patient will know whether A or B is the magnesium or the placebo. Nightly, when the participant takes the supplement, they are directed to call a toll-free number to input their personal identification number to account for taking the supplement that day, and this will help ensure patient compliance. Anyone that misses more than one day throughout the duration of the study will be asked to stop the study and their data will not be included. Participants will receive no dietary advice until the completion of the 4-week study. After the study, an optional free dietary counseling session is offered. And these individuals have just slightly elevated blood pressure, so they're not at like a huge major risk within just a month time period of going about their regular day-to-day lives. But of course, if a patient does not want to complete the study and has stage 1 hypertension and wants to discuss with their doctor taking medication, they're obviously welcome to do so. That's up to the patient and the doctor. People that do choose to participate in this study will schedule a follow-up appointment with the same physician exactly 4 weeks after their initial intake. At their 4-week follow-up, the intake nurse will again use an Android device to monitor blood pressure 3 times, 4 minutes apart, to be recorded next to their identification number. Here is the sample of what the sheet would look like for individuals that get the jar A. The first person will get jar A and the date will be recorded just to make sure that at the follow-up it's exactly 4 weeks later. And the nurse will just do 3 blood pressure readings under intake 1, intake 2, intake 3. And at the 4-week follow-up, they'll do the same thing. And then during analysis, the averages will be done. And as you can see here, every other person will get jar B. That's 2, 4, 6, and so on and so forth. And these data sheets will be kept in manila files labeled A and B. They're going to be kept in a locked cabinet along with the jars of supplements, the Android device used to monitor the subject's blood pressure, and the writing utensils needed to record the data. So the same Android device will be used for everyone, and all the materials will be there in that locked cabinet. The key to the cabinet is going to stay in the participating doctor's private office in a location only known to them, and this will ensure that that information just stays private, even though it's just identification numbers, no names. The patient is responsible for disposing of their supplement jar that was labeled with their identification number on it at the end of the study, and there will be no way to track the patients to the data besides by the date of their intake appointment, but that would require someone to have access to the patient's medical records, which would only be their doctor, who should already know what their blood pressure is. Now, the statistical analysis part is not my strong suit, but I believe I've worked it out here that to calculate the sample size needed for this study using G-Power software and a priori statistical analysis was done using a t-test involving the difference between 2 independent means. Using an error rate of 0.05, a power of 0.8, and a medium effect size of 0.5, the total sample size I determined was 128, which seemed a little low to me, so I may have to rework that. But this means that 64 people have to complete the study taking jar A, and 64 will need to take jar B. The data will be entered into a Microsoft Excel spreadsheet and then rechecked by another individual to ensure the data was properly transferred. And this is all identification numbers, so nothing can be tracked to the participants. And then using the simple Excel formula for averaging, the blood pressure rates will be calculated for each individual's average for their intake and their follow-up. And Excel will also be used to do a means comparison of the 2 data sets to get the central tendency and to determine if there's a relationship between the magnesium supplement and a decrease in blood pressure. Using the standard deviation formula in Excel, the variability of the data sets will be observed. The standard deviation will be divided by the square root of the sample size to determine the standard error and measure the precision of the results. Also in G-Power, a post hoc calculation will be done to determine the power of the study. And here are my references. And I thank you very much for listening, and I hope that you have a great day.